going to switch gears to the pregnant patient now. We're going to talk about uterine hemostasis and an update on the management of postpartum hemorrhage. And our presenter is Dr. Chad Grotegut. He's an associate professor of obstetrics and gynecology at Duke University. He's one of my partners there. He's a triple threat. He's got an R01 under review now in basic science related to uterine hemostasis. He is our medical director of labor and delivery, and he's a wonderful teacher and colleague. Thank you very much, Chad.
Good morning, and thank you all. I appreciate the opportunity to be here again. This organization, pointed out, is amazing, and I think it's a great example of the importance of interdisciplinary work, not only for research, but for provider education, patient education. So I think you all need to take this show on the road and educate a lot of other disciplines about the importance of this. So the goal today, I left all of my basic science slides at home. And I think the goal on this was, in terms of the update, knowing that the majority of the participants are non-obstetricians, this is really just a kind of a high-level review of what we do on labor and delivery to both prevent and treat postpartum hemorrhage, and what we've done behind the closed door before you yourselves, our blood bank colleagues, or interventional radiologists get involved in, just to kind of get an idea where we are. So we'll go from there. So postpartum hemorrhage has traditionally been classified as primary or secondary, depending on the timing in which that the hemorrhage occurred. So primary postpartum hemorrhage refers to that hemorrhage that occurs within the first 24 hours after a delivery, while secondary is often referred to later delayed, and that occurs between 24 hours and 12 weeks after delivery. The etiology of these are highly different, but today we're going to focus on primary postpartum hemorrhage. Classically, and we heard about this yesterday with Luis, is that classically the definition for postpartum hemorrhage revolved around, or was really dependent on mode of delivery, where a hemorrhage greater than 500 milliliters after a vaginal delivery was considered a postpartum hemorrhage, while that was with cesarean delivery was greater than 1,000 cc's. There's been a transition to get away from the kind of importance of mode of delivery, and the Royal College a few years ago kind of classified their definitions that got away from the mode of delivery component and defined a minor postpartum hemorrhage as that which is between 500 cc's and 1,000, and major greater than 1,000 cc's. I think it was in 2011, an international expert panel was convened that included a number of individuals in the room here today, and that group defined postpartum hemorrhage as active bleeding greater than 1,000 cc's within the first 24 hours following birth that continues despite the use of initial measures, including first-line uterotonic agents. And then Luis kind of mentioned what ACOG is using as today is that the definition of postpartum hemorrhage through their eyes is greater than 1,000 cc's with continued bleeding and signs of hypovolemia or other signs and symptoms of symptomatic anemia. So the incidence of postpartum hemorrhage varies widely depending on the criteria used to define it, and that's why as you get back to the literature, you'll see varying numbers. But traditionally, I think U.S. data suggests that the incidence is, and probably an incidence of significant hemorrhage greater than 1,000 cc's probably complicates 2 to 3% of deliveries. But the range that's most quoted that we see in the literature is 1 to 5%. Uterine atony is by far the most common etiology, making up 80% of the cases. It's a diagnosis that's made clinically, and it's somewhat subjective, but within our differential diagnosis for defining postpartum hemorrhage, we have to quickly rule out reproductive tract lacerations and retained products, as they make up the remainder of etiologies of postpartum hemorrhage. And then certainly medical bleeding and coagulopathy is a component of that. In our setting, typically often ends up being a result of the hemorrhage, but we certainly have those rare cases where women with primary coagulation defects present with bleeding at the time of delivery, but those tend to be more reproductive tract laceration type bleeding rather than bleeding from the uterine fundus. So let's focus on uterine atony. So this is some work that was conducted by Bill Callahan and his colleagues at the CDC, and they utilized data from the nationwide inpatient sample. And this is the changing incidence in postpartum hemorrhage over time from 1994 to 2006. And what you can see is that if you focus kind of on that middle, I guess I don't know what color that is, fuchsia, yeah, fuchsia, is that the overall incidence is increasing. And then what's driving that increase? Well, we clearly see that there's a component of mode of delivery that affects the incidence of postpartum hemorrhage, but whether a woman was induced or not clearly has some impact. Maybe not necessarily, we don't know if it's causative, but there's clearly some association of the role of labor induction with the incidence of postpartum hemorrhage. So here we see with the Duke blue line at the bottom, the rates or the incidence of postpartum hemorrhage among women who were not induced and had a cesarean delivery. And that pink line up at the top, those women who were induced. And similarly, we see the same for vaginal delivery. Which gets into the fact that my personal kind of both clinical and research interests have been surrounded around abnormal labor, oxytocin signaling, and oxytocin receptor desensitization, which we can talk about at the end. I forgot to mention that I'm a little worried about the stupid answers on my part, so we'll get to that. So uterine atony is characterized by inadequate uterine contraction following delivery. And we'll get to these shortly, these images that we have from our colleague Leo Brancazio. But basically, remember from yesterday's talk, the spiral arterioles are what supply the blood supply to the endometrium. And early in pregnancy, the spiral arterioles get remodeled into what we refer to, or commonly called uteroplacental arteries, or in our world we talk about uterine placental pipes. And these pipes, their kind of evolution, their importance in evolution is that they provide high volume blood flow to the placenta, and as soon as that placenta separates, these things are wide open. And so adequate uterine contractility immediately following delivery is an extremely important component of the initial prevention of postpartum hemorrhage. And then that then allows all kind of the local hemostatic factors, which you all are experts in, to then do their job. The etiology of uterine atony is not completely known. My kind of personal interest and bias is that, in getting back to the labor induction issue, is that the rate of uterine, or the utilization of labor induction in this country and across the world has been increasing over the last 10 to 20 years, and it's primarily been driven by, which is necessary because of increasing rates of medical complications of pregnancy and the association with stillbirth with these medical complications. And so there's this kind of risk-benefit of getting women in and getting them induced so that they prevent these awful outcomes of stillbirth. And so the induction is a necessity, but we don't know kind of what about labor induction increases the risk of uterine atony following delivery. My own work kind of suggests that, or I'm biased against this idea of oxytocin receptor desensitization. The oxytocin receptor is a G protein couplet receptor, and as a family, they're prone to desensitization. And as you give continuous drug, which we have to for induction with oxytocin, given that it's not active orally and that there's a very short serum half-life, that the receptor just doesn't like to signal in that setting, and you have to keep going up on these infusions. And what that results in following delivery is just a decreased responsiveness of our primary preventative and treatment strategy, oxytocin. So we'll kind of get to that. There are well-described risk factors for uterine atony. Kind of the greatest risk factors, besides prolonged labor, prolonged oxytocin infusion, is anything that overdistends the uterus. So we see that with multiple gestation, polyhydramnios, macrosomia, all things that kind of increase the distension of the uterus. And I kind of think of it as a whoopee cushion, or you get, like on the Starling curve with the heart, you get out there a ways, it so gets overly distended and it just doesn't want to contract as well. So uterine contractions during labor are characterized by this phasic pattern where there's a contraction, relaxation, and then immediately following delivery, there's this kind of an amazing transition from that phasic response to this tonic tetanic contraction. And what's quite amazing is, for those of you, if you remember from watching or either doing your C-section, or those of you who aren't obstetricians, kind of watching C-sections, that uterus turns white, and it's exactly what we want to see. It's I don't know what the right word is. It's ischemic. And if that happened to the heart, and when the heart was reperfused, that thing would blow up. And there's something magic about uterine myometrial cells that tolerate this ischemia that goes on for hours and hours and hours following a delivery. And that ischemia, or that white blanched uterus, is exactly what we need to see. This transition from phasic to tonic just still boggles my mind, and we're not quite sure what facilitates that. So labor, again, is characterized by this phasic contractions, and what that phasic contractions allows is for gas exchange in and out of the placenta, and then that postpartum state allows for, and that tonic contraction allows for the closure of the uteroplacental arteries that then stops the bleeding to allow the hemostatic agents to start doing their job. And then again, failure of producing that tetanic contraction then results in uterine atony and postpartum hemorrhage. So here's kind of a typical example of what, in a laboratory setting, what phasic contractions look like. So these are human myometrial samples. This is taken from Dr. Felipe's, one of his publications in the late 90s. And basically, when you take uterine muscle strips from mice, rats, or humans and hang them in a tissue organ bath, they just contract spontaneously by themselves. It's quite amazing. And as long as they're perfused with oxygen, they'll do that for hours and hours and hours. And then they're responsive to uterotonic agents. And so here's an example of uterine muscle strips that were treated with prostaglandin F2 alpha. And as you increase the concentration of the drug in the bath, you see an increase in contraction frequency and amplitude. And similar responses are seen with oxytocin. Here's one of those figures I kind of stole from Leo Brancazio, who's on the medical board of your society. But here we see is a schematic of the uterine wall and these uteroplacental vessels that are traversing the myometrium and providing blood supply to the intervillous space in the placenta. During contractions, the intramyometrial pressure is greater than the mean arterial pressure of those vessels, and so that those vessels close off. So during contractions, the fetus is basically looking at the placenta as a reservoir and taking the oxygen that it needs, and then it's not until the contraction is over that the CO2 can leave the placental bed and oxygen can get back in. This kind of gets then to what, in a laboratory setting, what that kind of tonic contraction would look like in a uterine strips. And rather than that phasic contraction, now we've got this prolonged high tonus contraction producing that ischemic response that we like to see in the uterus. So here we are now with separation of the placenta, and those big old uterine pipes are wide open. And in a normal delivery, immediately following delivery, we get that immediate transition to that tonic contraction. The intramyometrial pressure is greater than the mean arterial pressure. That closed down those big pipes, which markedly reduces the amount of bleeding from the placental bed, which then allows our hemostatic agents to do their job. In the setting of uterine atony, whatever that process that is prevented has not happened, and now we're left with 1.2 liters per minute coming out of the placental bed. So where do we get that number from? So we all remember from our training that there's a 50% increase in blood volume with pregnancy. And with that increase in blood volume, we see a 50% increase in cardiac output. And here we see the change in cardiac output with gestational age. Cardiac output kind of peaks at around 7.5 liters per minute in a normal weight woman, and that peaks at around 24, 26 weeks, and then remains elevated throughout the remainder of the pregnancy until after delivery. So of that 7.5 liters per minute, approximately 20% of that cardiac output goes to the uterus, and of that, 80% of that goes to the placental bed. So you can imagine now when the placenta separates and those big pipes are wide open, why that results in that 1.2 liters per minute, which is quite significant. So how do we prevent this? Well, we've been trying to prevent postpartum hemorrhage for years and years and years. In the literature, you'll hear about different kind of protocols or guidelines referred to active versus expected management of the third stage of labor. And again, the third stage of labor is the period from delivery of the newborn until separation of the placenta. And so what active management refers to is the use of a prophylactic uterotonic, and the most commonly used drug in this country and across the world is oxytocin. Early cord clamping, controlled cord traction, where expectant management referred to kind of just awaiting signs of placental separation. And once there were signs of placental separation, delivery of the placenta, and then the use of a uterotonic agent. There's certainly pluses and minuses to both approaches. Both utilize prophylactic uterotonics, which is largely universally practiced. I forgot what I was getting onto that. But anyway, people have, where we're kind of the controversies now occur in our field is the thought of the role of delayed cord clamping and how that plays a role in active management. And so what most centers, I think, are doing right now, especially for term infants, is delaying cord clamping for 36 seconds or a minute. Once they do clamp the cord, then most centers are helping to facilitate delivery of the placenta with controlled cord traction. And then the timing of oxytocin bolusing is different, but based on unit. Some give it right away after delivery, and some give it after placental separation. The worry about giving it right after delivery of the fetus is that there's slightly increased risk of retained placentas in that setting. On our unit, it's kind of provider dependent, but most of us are utilizing oxytocin infusions right after delivery of the newborn. So once uterine atony has been diagnosed, let's kind of get into the treatment phase. So a diagnosis of postpartum hemorrhage had been largely subjective. We're moving to more and more quantitative measures of blood loss rather than estimated measures of blood loss. You heard kind of Luis's approach of the role of estimated blood loss yesterday, and I agree with that. But with experience, we all learn that what we're seeing is, quote, just too much. I remember my first delivery as an intern at Duke back 20 years ago, and Bill Herbert, who was our division chief, was my supervising attending. And I was quite shocked about the amount of bleeding that was occurring at the delivery, and I kind of asked him what's too much, and he said when you can hear it. And that kind of gets at that 1.2 liters per hour, which clearly you can hear. The problem is that it's very easy to get behind. And that's why there's now tools that exist to estimate or quantitate blood loss. These include graduated measurement containers and drapes, visual aids that provide kind of representative examples of this is 300 milliliters in a chuck, but this is what it should look like. So you can use these visual aids to estimate what you're looking at. Wet dry weights, and then there's these newer optical technologies. One of those optical technologies is, I talked about, at the time that the diagnosis is made, we have to quickly rule out in our differential diagnosis again as lacerations and retained products. So as we're kind of initiating the call for medical management of uterine atony, we're quickly ruling out lacerations and retained products because those usually can be fixed quite quickly. In terms of optical technologies for quantitative blood loss, this is a product that's, I don't have any stock in Gauss Surgical, it's a private company, but this is a company that provides this tool called Triton, which is being utilized more and more on labor and delivery units. It's kind of a cool tool that what it does is it quantifies blood loss through a colorimetric assay. And so what we do is, of all the sponges that are in the surgical field, the nurses take the sponge, hold it in front of that iPad device, and then the iPad device can calculate the amount of blood that's in that sponge based on the colorimetric response. Similarly, in the canisters, it does the same thing. Unlike a trauma patient or a main OR patient where all of the blood that's in a canister is whole blood, the blood that's in these canisters is mixed with some volume of amniotic fluid, and the volume of amniotic fluid is highly variable dependent on the delivery, and it's led to a lot of the estimated blood losses from cesarean deliveries that we've kind of assumed was the truth. We've been overestimating blood loss on cesarean deliveries for a long, long time. So this is a tool that we found to be it's an interesting tool. And here's data to kind of validate this colorimetric assay. So here are three measurements. These are correlations between, on the y-axis, some estimation of blood loss. So on the far left, visual estimated blood loss. In the middle chart is a gravitational metric where you take subtract wet and dry weights of all of the sponges and chucks that are on the field. And then finally on the far right, the colorimetric method. And then on the x-axis is their gold standard, which was an extraction assay, which was their gold standard for quantifying blood loss. And what we find is that the estimated blood loss on the left, as Luis mentioned yesterday, is just not an accurate estimate of what actual blood loss is. And in our experience, and now that we've been utilizing the colorimetric assay, is that these estimated blood loss kind of overestimate blood losses from normal deliveries. The problem with an estimated blood loss is it's very easy to get behind, and that you've lost a lot of blood before you clearly recognize this. And this just shows you the correlation of the colorimetric assay with actual blood loss. So unit-based postpartum hemorrhage protocols have become kind of the standard for labor and delivery units across the country. They allow for standardized management for both prevention and treatment of postpartum hemorrhage, And they include, all these protocols include multidisciplinary team approach, which is extremely important. And so these multidisciplinary teams include obstetric providers, obstetric nursing, your lab. The lab obviously is a very extremely important component of how you manage postpartum hemorrhage, blood banks, and then our consultants in hematology and radiology, and then at the end of the day, trauma surgery. And these protocols have been shown to improve outcomes. They improve the time to cessation of uterine bleeding in the setting of postpartum hemorrhage. They show decreased rates of DIC and use of fewer blood products. The California Maternal Quality Care Collaborative is kind of the leader in postpartum hemorrhage, development of postpartum hemorrhage toolkits for L&D units. And so units across the country have access to their toolkits that can be adopted on their unit. And so our massive transfusion protocol was largely built around work from the California Maternal Quality Care Collaborative. There's a lot of really good information there, so I encourage you to check that out or have your obstetric colleagues, if you don't have a hemorrhage protocol in your own unit, to go to their resources. Medical management remains the first line for the treatment of uterine atony. We have access to various uterotonic agents that each target a different receptor or signaling pathway, with the goal of all these uterotonics is to quickly provide adequate uterine contractility to close down those large vessels. Clearly, blood component therapy and then surgical management are an important downstream treatment component of uterine atony. So oxytocin. Oxytocin is a funny beast. Here I was just telling you about oxytocin infusions are a risk factor for postpartum hemorrhage, but they're the mainstay of our both prevention and treatment. It's bizarre, and I don't have a good explanation for that, and we can probably talk more about that at the end. So oxytocin has this really cool history. The first kind of reported use of an oxytocin product in obstetrics was by this obstetrician Blair Bell in 1909, was the first to publish the clinical application of posterior pituitary extract. So they would take pituitary extract, I can't remember from what animal they came from, this was not humans. They administered it IM, and they utilized it for both prophylaxis and treatment of postpartum hemorrhage, and again was the first to use in obstetrics. There's some outstanding quotes, as in all of these old journal articles, but there's this quote right here that says, "There is no doubt, I think, that any one of these properties is sufficient to secure a permanent place in therapeutics for this much neglected portion of our anatomy." So I'm sure the endocrinologists would not like to hear that their favorite organ is neglected, but it's really interesting. But what was really interesting is that Dr. Blair recognized that, and in the quote said, it ought but rarely be given before delivering. I think he recognized that at the doses that they were using, it produced a tetanic response, and they even at that time felt that this probably wasn't good for the fetus, even though they probably didn't have a good understanding about gas exchange in and out of the placenta. Next in the 50s, here we are in New Orleans, Duvignon. I don't know if I could pronounce this, but here in JBC in 1949 published isolated pure oxytocin from the posterior pituitary. It was then proposed the amino acid sequence and structure for oxytocin, and then was able to produce a synthetic product that was indistinguishable from the natural hormone, and from all of this work won the Nobel Prize in 1955. So oxytocin is our utotonic agent of choice for both prevention of postpartum hemorrhage, so the use of oxytocin boluses right after delivery, as well as the treatment. And so as if anything, once we've diagnosed uterine atony, we give more. And so there's numerous regimens out there, but typically most L&D units utilize 40 units of oxytocin and 1 liter of normal saline or lactated ringers, delivered by a pump, and the rate is to control hemorrhage. There's no absolute contraindication to oxytocin, and again, the rates are adjusted to maintain adequate uterine contractility. When no IV access is, if women come in and delivering off the street and come in hemorrhaging and there's difficult IV access, it can also be given IM, undiluted 10 units, but IV boluses of undiluted oxytocin should be avoided due to risk of hypotension. I'm sorry that the banner didn't come through on here, but this is work from Dale in 1906 on the ergots. So the ergots are produced by fungi. I guess they're produced by fungi. They activate the alpha-adrenergic receptor system, and this was kind of the first work demonstrating the effects of ergots on blood pressure. So they increase blood pressure, and they also elicit a uterine contraction. Most common agent that we use is methylorganavine. It's given as an IM injection at 200 micrograms. Should not be given IV. We avoid it in women with severe hypertension and Raynaud's. The use in preeclampsia or other hypertensive disorders is kind of case-by-case basis. A lot of these patients become hypotensive, but we worry about the potent vasoconstrictive activity that it has. It's rapid, it has rapid activity, but if the first dose is ineffective, we'll switch to a different agent, which then leads us to the next class of agents, so the prostaglandins. The prostaglandins activate, work through a G protein couplet receptor similar to the oxytocin receptor. Both the oxytocin receptor and the prostaglandin receptor activate GQ, and when you activate GQ, increases intracellular calcium. What's interesting is even if a woman who's been exposed to prolonged doses of oxytocin is not responding to oxytocin therapy, they typically will still respond to prostaglandins, is that because the receptors are different, even though one has been desensitized, the other is still working. It's still active, and there's great basic science data to demonstrate this as well. Carbopros is prostaglandin F2 alpha. It's also referred to as hemobates, given as an IM injection. We do not give this IV. We avoid this, and it can be a potent bronchospasm agent, and so we avoid it in women with severe asthma. It can be repeated, and so we'll give dosing intervals every 15 to 90 minutes. Side effects are kind of classic. Almost every patient will get nausea, vomiting, and diarrhea, and so our nursing colleagues really don't like this medication, but it works quite well. Another prostaglandin that we're utilizing more and more is PGE1, or misoprostol, which works through a different receptor. It's useful when other uterotonic agents are contraindicated. It can be used in women with asthma and hypertension. The optimal dose in obstetrics, optimal dose and route is not clear. Most units give this, in the setting of treatment for uterine atony, give this rectally. When given rectally, it has a slow onset of about 1 hour, but it has a long duration. So we don't necessarily use this to acutely stop the bleeding, but we use it to maintain adequate uterine tone over the next few hours while our women are recovering. It's inexpensive, stable at room temperature, so it's a great medication. Fever is common, but again, it's not contraindicated in women with hypertension or asthma. Carbetocin is a long-acting oxytocin analog that's not available in the United States, but it's routinely used in both Europe and Canada. It's been modified to increase the serum half-life. So the serum half-life of oxytocin is only about 2.5 minutes, and this modification allows it to stick around for a lot longer. It's used not for labor induction or augmentation, but it's used for the prevention of postpartum hemorrhage immediately after delivery by cesarean delivery. We have some work in our lab that, even though it's been marketed and due to its longer serum half-life, but it looks like it also leads to less oxytocin receptor desensitization. So as a trainee, kind of my career goal was to identify a non-desensitizing oxytocin analog, and it looks like we already have one. What would be great is if we could figure out how to use this or a similar compound for labor induction to kind of prevent uterine atony down the road. Tranexamic acid we heard a lot about yesterday. I won't really go into, but we all know it's an antifibrinolytic agent. It's being utilized more and more commonly in obstetric units, both for the prevention and treatment of postpartum hemorrhage. As we learned from Luis yesterday, there's a large 11,000 subject MFMU trial going on to look at the use of tranexamic acid for the prevention of postpartum hemorrhage among women being delivered by cesarean delivery. For treatment, we all know the results of the woman trial, and kind of the big finding on that was that the use of tranexamic acid for the treatment in the setting of the treatment of postpartum hemorrhage showed decreased death from bleeding by subgroup. Important that this drug was, as we learned yesterday, be given within the 3-hour window, as that's when it's most beneficial. On our unit, we don't use TXA on all patients, clearly. And we don't necessarily use it for all atonies, but we use it whenever we activate our hemorrhage protocol. It's kind of where we are right now. The only prevention strategy that we're using it right now is we have a high-volume placenta accreta program, and so our OB anesthesiologists are using it at the time of delivery prophylactically, kind of without much data in that patient population as well. This is just a reminder that as part of our evaluation and during our treatment for uterine atony, that we are constantly removing the uterus of clots. And there's something funny about the uterus. Whenever there's large clots in there, it just doesn't want to contract down as well, and it ends up, we see bleeding and bleeding again. So we're constantly going up and we're evacuating clots, which kind of helps further elicit stronger uterine contractions. This is an example of a kind of a bedside cognitive aid that we developed that sits on the bedside of all of our patients on our unit. And it's just a quick reminder for our providers in nursing about all the various uterotonic agents that we have on our unit, the appropriate dose, route of administration, frequency, and contraindication. So we all know that in the setting of an emergency, in that we start forgetting dosing, and it's just one of those things just to kind of provide a safety, improved safety aspect. Which now gets us into surgical treatment. When our medical management fails, and our medical management, once we've made the diagnosis, we medical management, and eventually when they're not working, we now have to start thinking of alternatives. And so surgical treatments, primary goals of surgical treatment are to occlude the uterine cavity. And so we have a couple ways of doing that. One's a Bacri balloon or a Foley catheter, second's uterine packing, and then the others are these uterine suture braces, which we'll see shortly. And then when that doesn't work, we then start stepwise devascularization procedures of the uterus. And we start with bilateral uterine artery ligations. When that doesn't work, we go up top and ligate the uterine ovarian vessels. When that doesn't work, we call our IR friends and get women down for uterine artery embolization, or proceed with a hysterectomy, which is clearly the definitive therapy, but clearly some downstream issues with that. So here's a Bacri balloon. These are what are used to obstruct the uterine cavity, and basically what we do is pass these balloons up through the vagina and into the uterus, then fill them up. Often we will use an ultrasound with it just to make sure that the placement is correct. And what that balloon does is just kind of puts pressure against those uteroplacental arteries to decrease bleeding. We leave the balloon distended for about 24 hours and then deflate and remove. This is an example of what's called a B-Lynch suture. It's a suture brace that basically does the same thing as a Bacri balloon, but instead of occluding the balloon from inside, we place these suture braces on the outside of the uterus. And basically, you see the picture on the right, what that does is cause the uterus just to, it just closes off the cavity. So the potential space is gone, so there's nowhere for no place for that blood to accumulate. Our kind of decision points about when to do each of these are based on mode of delivery. And so if a woman is open and we've had a cesarean delivery and we encounter uterine atony, we typically, because her abdomen is open, we'll place a B-Lynch suture. And if she's had a vaginal delivery, then we'll place devices from below, a Bacri balloon or Foley catheter. You can place the Bacri balloons from above during a cesarean delivery, but I just find that it's extremely awkward. And so our practice is typically to place a B-Lynch suture. There's a new company out that's doing a trial across the country that has a new device that goes into the uterus that rather than have a balloon that distends the cavity, what it does is this device goes in the uterus, it provides suction, and it causes the uterus to kind of shrink down on itself. And so that trial is undergoing right now, so we should have some data on that device shortly. Again, we talked about the importance of identifying cervical and vaginal lacerations and making sure that those are repaired. Looking at careful visualization of the placenta to rule out retained products. That usually can be fixed with manual exploration. We also utilize ultrasound to help diagnose these conditions. DNC, large bangiocurettes, can also be used to help facilitate removal of placental fragments. Certainly in women with retained products, we start worrying about could she have had a partial accreta, which then gets into a whole new topic of conversation maybe for next year. So in summary, the obstetric management of postpartum hemorrhage, clearly we have to be prepared and anticipate this for any delivery. We learned about the importance of early diagnosis given that how much blood loss can be and how quickly we can see profound blood loss. Differential diagnosis not only includes uterine atony, but lacerations of the reproductive tract and retained products. Uterine atony treatment, as I mentioned, medical management, more medical management, more medical management. All of these uterotonic agents are designed to keep that uterus contracted, close off those uteroplacental pipes to give the hemostatic components that you all are experts in time to work. And then when that doesn't work, then we start down our surgical management options. Certainly, multidisciplinary massive transfusion protocols and unit-based protocols are extremely important at getting people together very, very quickly. Our protocol, when we activate it, the director of the blood bank runs up to the unit. Blood is kind of how our blood component therapy works on that. Every unit is different, but we're still have adopted a one-to-one transfusion guideline protocol, I guess. When we activate the massive transfusion protocol, what we get is 4 units of packed cells, 4 units of FFP, and a unit of cryo. Our protocol differs slightly from the rest of the hospital in that our first release for us includes a unit of cryo, where for everyone else, transplant, the rest of the hospital, they just get the 4 and 4 and not the unit of cryo. And that's regardless of what the fibrinogen level is at the time of the diagnosis. The cryo will automatically be thawed. The risk of that is that we waste units of cryo, but often, hypofibrinogen is such a common component of these kind of disasters that we end up using in a lot of the cases. The second release is 4 and 4, and then after that, our labs get sent out every 30 minutes. Now, a lot of it's due to the work that Homa did as a fellow in our group, but includes ROTEM as every 30 minutes that it gets included in the lab panels that are being sent out. And our anesthesiologists are kind of transitioning more from just a rote one-to-one transfusion practice to more of a laboratory-based transfusion practice once they get after that first or second release. And they'll use their ROTEM results, the results of their fibrinogen levels and the such to kind of guide their transfusion therapy. There are numerous research gaps in this area. I think as a simple obstetrician, we're kind of hammer and nail, and we focus really on maintaining uterine contractility because we firmly believe that if we can, that plays such an integral component in what drives the risk for uterine atony that we need to focus on that. But clearly, as we learned yesterday from Julia's talk and Luis's talk, it's not the only thing, in that it's people like yourselves that will help us figure out what besides adequate uterine contractility will help facilitate prevention and treatment for postpartum hemorrhage. With that, I'll have to take any questions.
Thank you.
Hi, Julia Coleman, Denver
Yes,
Trauma.
ma'am.
Thank you for a fantastic talk. Sure. I have several questions. First is when you allude to the ROTEM-based resuscitation strategies. So we have tried to adopt a TEG-based resuscitation strategy for postpartum hemorrhage at our hospital. And we've run into issues where the lab says, well, timeout, you can't really do TEG-based resuscitation in these patients because we don't know what the normal ranges are.
Right.
And we don't actually have CLIA-approved normal ranges for viscoelastic parameters for postpartum women. So that's actually what has inspired now our ongoing longitudinal study at our hospital to try to establish that at our own hospital. But can you speak to whether you've run into that issue, and if so, how you're getting around that is my first question.
It's a great question. Some of this is now in an evidence-free zone, which my wife, she's an internist, so she accuses that we're working evidence-free zone. But so our ROTEM, the images pop up in our lab in the workflow in the OR, and so a lot of this, I think, there's not great evidence behind it. But if they start seeing signs of clot breakdown on the ROTEM coming out, then that's when they'll start utilizing TXA or the other components there. So I don't have a great answer for you, but except that I think right now we're utilizing it clearly in this kind of evidence-free zone. And as a group, I think over time we've seen lower rates of product utilization, lower or nadir fibrinogen levels being higher and with less time. So is that a component of utilization of lab-based transfusion practices? I'm not sure.
Sure. And another question.
But it's a great way for us to collect data and see what happens with them.
And I also think is an opportunity for inter-institutional collaboration. So I'd love to talk to you offline about that as well. But another question I had, not talking about using TXA preemptively, but using it in the treatment of postpartum hemorrhage, do you do that only with biochemical evidence of hyperfibrinolysis? And if so, what are your thresholds?
Yeah, so we don't necessarily, and a lot of that is a gut-based feeling from our anesthesiologist. And what we're getting to at the point right now is if the hemorrhage feels significant enough that we're activating our massive transfusion protocol, then they're giving it. And a lot of that is based on just, I think, that trying to stay on top of it rather than waiting 30 minutes to get our ROTEM results back, or 15 minutes to start seeing changes. And so again, it's more of a gut feeling response right now rather than a true evidence-based act on this laboratory value.
Great, thank you. And then my last question, I'm hogging the mic. Last question is, I think one of the things that's similar about TIC and PPH is that you have mechanical bleeding that, if you don't address early, becomes coagulopathic bleeding. And it's something that I talked about a little bit yesterday. But one of the ways that we have tried to mitigate that in trauma is with the use of Reboa to halt mechanical bleeding before it turns into coagulopathic bleeding. And Reboa, resuscitative endovascular balloon occlusion of the aorta, where you go through the FEM and inflate the balloon, zone 1, zone 3, to essentially, it's your now non-invasive way of avoiding an ED thoracotomy and a knuckle on the spine. So one of my questions is, there is some data on the use of Reboa preemptively in women with placenta previa and placenta accreta. But can you speak to what you see as a potential role for Reboa and PPH, and why that hasn't been adopted more readily? Because I think it could be a really powerful tool to prevent some women of converting into coagulopathic demise.
Yeah, it's a great question. So I first heard about Reboa maybe 6 months ago when one of our OB anesthesia colleagues came back from the SOAP meeting, or some meeting, and was all gung-ho about putting these big balloons in the aortas of women on their unit. And I think some of it is logistics, and that having access to this, and so it just is in its infancy in obstetrics, and it's one of those, I think, research opportunities that rather proceeding directly to hysterectomy, or getting into a component where we're now in DIC because we've behind the 8 ball in terms of how we're managing it, that maybe this will become standard, but certainly is not yet.
And maybe you could say something about the placement of catheters.
And placement of catheters and accreta. So,
More localized.
so for the management of placenta accreta, again, is an evidence-free zone. Every unit has their different preferences. We don't use Reboa routinely. We don't use it at all in our accreted patients. We used to place uterine artery balloons routinely for all of our cases, keeping them deflated, then only inflate them at the time if we needed them. We didn't use them a single time. And so we've now gotten away from even placing uterine artery balloons on these patients, which that's a whole nother discussion that we can, about accreted management, we can talk about later.
One of the issues that we run into where OB-GYN will say, well, gosh, I can do an emergent hysterectomy faster than it would take for trauma to come and put it in Reboa. But I think if you have a facility where you have in-house trauma that can put in a Reboa and inflate it in 75 seconds, that it's worth exploring if it means avoiding a hysterectomy.
I agree, and I think that I'm in the camp that we can get a uterus out pretty quickly, but if we could avoid that, then that would be great. And there's certainly research opportunities for other avenues. Sir?
Peter Queeditz, University of Rochester. Thank you for a great overview. Sure. When you reviewed the uterotonics, it was in terms of sequential management. But in our bleeding disorder patient, do you think there's a role if we have a type 3 von Willebrand's or someone with prior, massive hemorrhage who's now delivering of double uterotonics? And what would that be prophylactically?
So we do, this gets, again, in an evidence-free zone. So patients who are in our unit who are high risk for hemorrhage, regardless of the etiology, whether they have a bleeding disorder or whether they have a history of significant postpartum hemorrhage, or they're carrying triplets, we do kind of evidence-free double, triple uterotonics. And typically what we'll do is, right with delivery, give our large bolus of oxytocin. We'll place rectal misoprostol in, and that's typically where we start, and then have our other agents available. But again, it's provider dependent.
So, Roshni Kulkarni, so I'm coming from the other side of the placenta, pediatric side. So I'm just wondering, are there any consequences?
There is
I know
another side.
postpartum hemorrhage is like postpartum, but are there things that begin before the baby is delivered that influences the baby? What are the effects on the baby? And, like prematurity versus respiratory distress versus, I mean, I'm just wondering if there is a body of literature looking into that.
I'm not sure I understand in terms of risk factors that the fetus may bring to the pregnancy that then contribute to.
Or the risk factor that the postpartum hemorrhage in its very early stages has on the fetus.
Oh, clearly. I mean, the one that's the one that's most studied is Sheehan syndrome, is the effect of inability of women to lactate following a delivery. It's one of those things that we all learn about. I think I've seen 2 cases in my career. So there's clearly that effect, but I can't really think of any other.
Unless there's placental abruption.
True. Yeah, and there's placental abruption, which could decrease oxygen
Right.
delivery of the fetus.
My name is Maria Noreen. I'm a nurse practitioner in Long Island. I work with Dr. Acharya. And this talk hits home because my daughter at 30 years old had a postpartum hemorrhage. She was a high-risk pregnancy to begin with. She had a malignancy, cancer diagnosed when she was 16, and had pan-hypopit. So we went in knowing she was already high risk. We had the team, and I'm sorry if I'm a little shaky here because it really, what you talked about kind of covered everything
Sure.
we went through. But what I wanted to bring to the situation was that I'm sitting in the waiting room and not knowing all this is going on within the first hour after delivery. And the pictures you put up there really explained a lot. She just kept bleeding and she was hypovolemic. My son-in-law was watching her while he's holding the baby, and it was so orchestrated, the team, that they knew exactly what to do. The hematologist was there, everything you mentioned, it was amazing. My other daughter was in the elevator while the blood products were being brought up. So the question was, after all was said and done, and they said it was a uterine atony, she survived everything. She ended up with an arterial blood clot from a line and pulmonary embolism. So the next time around, what do you do? So she, again, it was unlikely for her to become pregnant. She didn't lactate afterwards. We thought it was from her pituitary malfunction. But we had a big team meeting, and the focus was more on the thrombosis risk than the bleeding, with the 80% chance that it would happen to some women. So they opted to do an elective C-section, which I found on your slides, where that would be a higher risk for bleeding. And the thought was that since she was already open, they can control the situation better. And I'm not sure what the answer, which way it would go, but it was really left in the hands of the specialists. They did protect her from any thrombosis. That was the whole plan all along. But the bleeding risk was what I was worried about, was like, how do you know if this is going to happen again? Which luckily it was very planned. The delivery for my grandson, who's 1 year old, my other grandson is turning 3. So it was really, I don't think we have all the answers to what to predict, and it's a very scary situation not knowing, and should it have been the second one a VBAC or not. And I think it was just because they can control medications, everything on a surgical setting, than if it was vaginal. I'm not sure what the answer.
It's a great point, and I think that, thank you for sharing your story. From Bill Callahan's data, it probably suggests that an unlabored C-section probably has the lowest rate of postpartum hemorrhage, but even though the median blood loss at that delivery is going to be greater. The problem with these C-sections is, and someone who's had a VTE in the past clearly, is that pelvic surgery is going to increase her risk for VTE over and above the vaginal delivery. So again, we don't have a right answer for that, and research opportunities we need to better understand what leads to uterine.
I'd just like to say that the risk of we know from 2 randomized trials, the breech trial and the twin trial, that there is no difference in blood loss with elective planned cesarean delivery versus planned vaginal delivery. So there seems like in that situation there were compelling reasons to choose the planned cesarean.
Very nice talk. Ravi Sarodar from Dallas. So I do transfusion medicine and hemostasis, and I'm at Parkland, and we use whole blood for OB. Any comment on that? Because it seems that whole blood is coming back in massive transfusion protocol as part of trauma. And we did some kind of, so when I came there, I said, whole blood, not a good idea. No one uses whole blood. That was 20 years ago.
Yeah.
And we had an extensive discussion with OB, and I got their point that someone who's hemorrhaging massively, they may need whole blood. But what they were doing, they were using whole blood also on the floor when they had postpartum scenario with low hemoglobin, and they being whole blood. I said, that's not a good idea. So we did a study to show that whole blood is beneficial during delivery when they are actually hemorrhaging, and they had less ATN, and they had better outcome as opposed to when they were getting whole blood on the floor when they had more pulmonary complications.
Right.
So have you ever thought about using whole blood, because now it's coming back?
I'll have to defer to Andy, and at risk of a stupid answer. We think about it. Our blood bank right now, they're still releasing packed cells to our unit. We've had some of those discussions, but our blood bank, and we haven't pushed to convert to whole blood for these patients, and our blood bank has been comfortable with the current products that are being
And
released.
Jack Pritchard, who was the lead editor of the classic Williams Obstetrics and a grandfather to all of us in OBGYN, espoused whole blood and was there at Parkland and has left you his legacy, apparently.
And that's what they keep telling me every time. So.
Even in the new building, I guess, right?
Yeah. The second question is, when you say you also get cryoprecipitated with the first shipment, because cryo is always frozen, how long it takes for you to get the first shipment? Because when we started massive transfusion protocol in Parkland in 2003, I really wanted to use cryo as soon as I could, but there was no way we could prepare within first few minutes, because you can have liquid thawed plasma, you have red cells.
Yep.
First shipment is gone in 8 minutes.
Yep. So what happens is, as soon as we activate the protocol, the blood bank releases the 4 units of packed cells and the 4 units of FFP. Those come up to the floor immediately, and they start thawing the cryo. And as soon as it's thawed, then that's brought up.
Okay, so it's not. And then as regards ROTEM, where is the ROTEM located?
So the ROTEM machine is located down. It's a point-of-care test. It's not down in the main lab. There's an area not in our unit, but it's down the hall toward the surgical ICU unit. And so we have a runner that takes those samples every 30 minutes to run, and then so that's brought down, and then it's the images
So
are
display is there.
Yes, sir. And those
So
images,
I just want to clarify that it's not still a point of care testing, because it's a point of display.
point it just right.
Because everyone thinks it's a point of care testing, so it's not like doing a finger
Right.
stick. So I just
Good
want
point.
to clarify it's point of display, because you still have to send samples somewhere else to
Right.
do it. And then we've been using ROTEM, but the parameters that we use for managing any bleeders is the same across the
Right.
bleeders, because if you see low MCF or prolonged CT, you just act on it, because there are no differences in OB versus non-OB parameters.
Yeah. To get to Julia's point too, is we're sending ROTEM along with all of our labs every 30 minutes. So I think there's a great research opportunity in there to see how these profiles change with time and in response to various agents in a pregnant patient.
Hi, this is John Bernstein, Connecticut. Maybe coming out of left field, but just as a question, electrical stimulation. Has anyone, and it may be many years ago or anything along those lines, any looked at direct electrical stimulation to the uterus to cause contractility or improve contractility in patients on oxytocin?
It's a great question. And so one of my colleagues at Duke is a urogynecologist who, of all things, is interested in preterm birth. And he feels that the uterus is just like the bladder, and that the anticholinergic system he feels is very important for innervation. They similar innervation, I don't remember all this from med school, but they have similar innervation pathways. And he wants to use the anticholinergic drugs they use for the treatment of urge incontinence for tocolysis. So on the reverse, it's preterm labor treatment. So as part of that research, we took myometrial samples from mice and put them in our tissue organ baths and electrically stimulated, and they did nothing. So again, these are versus if you take skeletal muscle and put them in those same baths, it elicits a contraction. So again, the tissue is removed from the innervation in the bath, and so are they not responding to the electrical stimulation because they're now removed from this? I don't know, but that's as far as we've taken it. I'm not aware of any in vivo work to stimulate the uterus to affect contractility, but it's a really interesting thought.
Hi, that was a great talk.
Thank you.
I'm Caitlin Moncrief. I'm a pediatric NP at Rhode Island Hospital, and so while I don't have a ton of pregnant patients, I have had a handful of adolescents that with bleeding disorders that become pregnant, and with working with MFM, we're often trying to get a really good plan in place and be ahead, and a lot of them want an epidural, so we're having to make sure we get factor into them on time. So a lot of the MFMs will recommend induction, but based on the data too, it looks like any induction is going to increase the risk of postpartum hemorrhaging. Can you speak to weighing that induction to make sure they're not delivering at 2 a.m. and the plan is foiled and they don't get the epidural? Or
It's a great question. So our practice has been, so women who are on anticoagulants, we risk benefit and we prefer that they come in for an induction. A lot of that is that just so that we maintain their ability to have regional anesthesia as an option for their labor. And that's the rationale for that. And the thing is I don't want to paint this picture that all women who are induced are going to bleed like crazy. And that's clearly not the case, but it is probably an important risk factor. And so it's, again, one of these balances. And then for women with other bleeding disorders, factor deficiencies, or I agree with that, this opportunity to make sure everyone's in place and that it plans in place, and it's not happening on Sunday at 2 o'clock in the morning when everyone's down at the beach. So, thank you all very much. Appreciate it.
Fabulous talk.